So can you talk about then both, so the types of kind of key clinical things you'd be looking at for reasons for why to put one in the first place, and then what are or how do you know when decannulation might be appropriate?
So going in, you would put a trachea in. You try to do one as early as possible if somebody's had one failed extubation. So we would attempt an extubation.
What's one failed extubation?
So the patient will come in with an ET tube to start with. They'll have an oral, tends to be an oral endotracheal tube.
Okay.
So once you've weaned the patient to a set point, you'll take that tube out. If that fails and it needs to go back in, then at that point they'll think we're going to need to tracheostomy this patient. So if there's one failed extubation, they'll go for a tracheostomy. It used to be that we were trying to have done it by about day 10. Doesn't always happen because you need the patient to be stable to do the tracheostomy. So it used to be that we were trying to have done it by day 10. Some units are within 72 hours, some are longer. I don't know why we were always about day 10.
Yeah, the Trackman trial, there was a trial where it looked at early tracheostomies and actually the evidence didn't make a difference.
But it'll be things like, is the patient struggling with a tube? So is the tube causing a lot of irritation to the patient? Are they biting the tube? Are we really struggling to get the secretions up the tube? So there'll be lots of clinical decisions as to why the ET tube will be changed to a tracheostomy. But once the tracheostomy is in, the patient can feed better, drink better, mobilise better, is a lot more comfortable. You don't have the risk of all the tapes causing sort of pressure sores and things.
So with your particular patients, it will tend to be the ones that, because they're neurologically not awake,
they're not going to get off the ventilator.
So those will be the main decision for tracheostomy. Giving them a tracheostomy is the fact that they're not awake enough to actually protect their airway.
And they're not going to get off the ventilator for weeks and weeks, and you know that you're going to need a tracheostomy to get them off. And then once the trachea's in, you can wean from the ventilator because there's something protecting the airway. You've got something to access the secretions with. And it's much easier to clear somebody's chest with a tracheostomy than it is a long ET tube. A lot less dead space as well with a small tracheostomy than a long ET tube. So there's lots and lots of advantages of going to a tracheostomy for the patient, but also for us managing the patient. So that'll be why the trachea goes in, and then the decannulation
will depend again on their conscious state. So are they able to protect their airway,
what
their secretion load is like, what their ventilation is like, are they managing to maintain, can we get them off the ventilator? So first of all, can we get them off the ventilator? And if we can get them off the ventilator, then are they managing to clear their chest independently will be the biggest reason why we would keep a tracheostomy in. And are they protecting their airway? Those two reasons really would be why we pretend. And what we'll tend to do is downsize. So we'll start with a 7 or an 8 tube, then it will go down to like maybe a size 6 tube, so that we know that we're there purely keeping that airway patent and to give us a means of being able to suction. Occasionally we'll go down to a mini trachea, but a mini trachea has its problems. It's a very, very small tube. It's purely there not to ventilate through but to clear secretions. So if someone is productive but they're actually ventilating okay, then we'll go on to a mini trachea, but they come our and our wards don't like them at
I think
all.
we're the only unit that's still using mini tracheas, to be honest. I think the rest of Wales has stopped. I think the rest of the UK has stopped.
With kids fall out all the time, but they can be helpful. They can be helpful because instead of having to do lots of nasal suctioning, you've got a means of being able to clear them. And with patients especially that have downsized down, you're not actively
putting a new one in.
You're basically going smaller. It's just another means of being able to clear their chest. And probably, as I say, sputum load is one of the biggest reasons why they will be the thing that actually means that they pass away or not, really, because that will be the pneumonias of the ones.
And load means amount and
large amount,
type of secretions, or just the amount?
It's often amount, and it tends, because there is a large amount, it tends to get repeated infections. It's the volume of it they're not clearing effectively, that means that it's sitting in their lungs, which means they're more prone to getting infections, so therefore you kind of end up in a
and you're also getting to the point where you're starting to try and potentially give the patient food and water already.
Yeah, that's true.
And then if they're not swallowing well, they tend to aspirate. So that'll also sort of influence whether they get another chest infection at that point, because we've been trying to feed them before their swallow's ready. But you want the trachea out in order the patient can start swallowing more naturally. So it's a very fine line at that stage between all those things and getting the timing right between them all.